Can you see my screen, by the way?
Yes, perfect.
Perfect. Awesome.
Yeah, I'm just trying to
Let's give it
make
another
some
minute or
persons
so.
full. Uh, First, so they can help me. In, okay. Yeah. Hmm, okay. So if you are a co-host, there are some persons that I've met co-hosts. You can help me to accept people and other things. So we're starting soon. Um,
That's meant writing you have expressed confidence about the letter and 2026.
Okay, hello, greetings everyone. Thank you so much for making our time to be here. This is our second cohort. The first cohort was exceptional, and this cohort we've been having interesting moments and having nice conversation. Today we'll be having one of the finest longevists in the continent of Africa. You know, and he is an African true and true. I forgot about his color. He's so passionate about Africa, and sometimes we stress him so much. My friend Emilian Popa, the last time we had the event in South Africa, 2023, right? So he was really stressed. He flew in. He was going to Europe for an event, so he decided to stop, and it was just a whole lot of stress. So he moved from an event to an. He travels virtually every time. He's always flying around and presenting translatable longevity protocols and got centers in Africa. he started in South Africa, and he's doing so much in East Africa. And I hope that he expands um, more to Western Africa. So he is a health tech entrepreneur and a longevity system builder who focuses on integrating preventative medicine, biomarkers, just omics technologies, and AI-enabled clinical infrastructures across emerging markets. So he is the founder of Expand Health, um, a platform that combines diagnostic, structured longevity protocol, and digital clinical support tools to operationalize scalable healthcare models. Emilia, you've founded a whole lot of companies. Like every two years, you are now a founder of another company. So kudos to you, my brother. Thank you so much.
Ah,
I yield the mic. So tell us a little bit about your background, and then we get into the conversation proper.
thanks, thanks, Ossie. Good to see you again. And yeah, it's been a while since we met in South Africa. It's really an honor to be here, part of this incredible program. So thanks for giving me the opportunity to speak alongside other leading voices. So as Ossie said, I'm Emilian. I'm the founder and CEO of a company called Expand Health, and for the past 3 years, we've been working on a question that keeps me up at night, which is how do we bring world-class longevity medicine to Africa? And it's not simple. And it's not in 50 years, but it's actually right now. And I think this is the complexity. So tonight, I want to share what I've learned building scalable longevity systems across the continent. But I also want to be honest about the challenges because there's a massive gap between the longevity vision and what the African reality is. So let's dive in with a couple of numbers here. So, nothing that you don't know here. We live in, I'm in Nairobi now, so I speak from Nairobi. Africa is the youngest continent on earth, and the median age, um, is 19 years. But here's the paradox: we also have one of the highest burden of preventative and age-related diseases. Call them, diabetes, cardiovascular disease, hypertension, cancer. And those are not the problems of the elderly anymore, like in the Western world. We're seeing metabolic dysfunction in the 30 years old, which is crazy. We see heart attacks in the 40s. We see type diabetes in teenagers. And we wonder why. And it's because the healthcare infrastructure was built for acute care, right? Not longevity. And we treat disease and we don't optimize the health. So, we react to symptoms and we don't predict and prevent. And I just want to stop here for a second. And one thing that it's another company I built back in 2019. I've been running for 5 years, Ilara Health in Kenya. And interestingly enough, in one of my employees in Ilara, it was like 2 or 3 years ago, somewhere in Western Kenya, we were having coffee with the team, and she told me she was 20, and she told me, I need to take my metformin. I was like, why? It's like I had diabetes. I was like, diabetes type 1. It's like, no, 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 diabetes type 2. And I said, you're 20, and this is reversible. And she said, no, I don't know. My doctor, this was in Kisumu in West Kenya. My doctor said that I need to take the treatment, and she was still eating, a lot of high sugar and the whole story. So so I think what's very clear here is that we talk about it's a gloom story, right? And it's very sad because you know we don't measure, we don't know, and a typical patient in Lagos or Nairobi or Johannesburg, gets a really basic blood panel and maybe once in few years. So I think, I really think this is an opportunity of a lifetime because just so many people on this continent. And by 2050, I think we're going to be what, 2.5 billion? I think we're 1.5 billion today. And we have this growing middle class, which is demanding better care. And we have all the tools on this continent. We have massive mobile penetration, way bigger than anywhere in the world. We have massive urban center. We have great people and fantastic engineers, right? Some of the best startups in the world come from Nigeria, actually, funny enough, right? But there is a critical problem. We don't have systems. We have this old-fashioned healthcare which doesn't think preventative. So really before we talk about where are we going, I really want to be honest here. And I think, also you and I have had a lot of talks about longevity in Africa, and there is a reality here, right? There are two fundamentals barriers to define what we can do about longevity. And we shouldn't ignore them. And one of them is cost, and the other one is knowledge. So we're going to look at a couple of numbers here, and you may recognize some of them. You may not know how much a Kenyan or a Nigerian spends in the whole healthcare ecosystem, the whole ecosystem, pharmaceuticals, primary care, secondary care, hospital. It's $50 in Nigeria, I think 70 in Kenya, about 500 in South Africa. And you compare these to about $20,000 in the US, right? Just what can we do with $50 in a year, right? You can't really do, a basic blood test. And my former company, Lara Health, we've been doing basic blood panels and basic diagnostics in the mid to low income. We know that a basic full blood count costs $10 to $15, and this is pretty much this is like 1/3 to 1/4 of what the whole spend in healthcare in a year. The Nigerian entire annual health budget is less than what one blood panel costs at a longevity clinic in the US. The clinic's charging hundreds of dollars for basic blood tests. So when the total healthcare spending is so little, a comprehensive blood panel is science fiction, right? Most patients have to choose between foods on one side and blood tests on the other side. And companies like Ilara Health, my former company, we're still fighting basic care, and we bring basic care. And we can ask ourselves, what do governments do? Well, not much, right? They spend a lot on acute care, on maternal health, but very little on anything else, very little on preventative. And also, I mean, the basics, right? Western world covered by insurance, right? US, Europe, 85, 90% is covered. South Africa, about 15, 16%. Kenya, 2 to 3%. Nigeria, slightly higher. And there's a private insurance penetration. I mean, the public, national health insurance, it actually covers really basic stuff, really basic stuff. So you can't really do much about longevity using state insurance. So even when people want preventative care, I think the economics make it quasi impossible. And longevity remains, unfortunately, a privilege for the riches. And the second barrier is knowledge. I mean, I still remember in Ilara Health, I was going to West Kenya and interviewing some of the nurses in small clinics, and was talking about some basic biomarkers, hemoglobin A1C, or they had no idea what was talking about. There was like hemoglobin what? So even basic knowledge on the health workers is a massive problem. And when on one side the people don't have money, and on the other side the health workers, who are mostly clinical, like nurse practitioners, not really doctors, don't know, then what happens? People go to see a clinician when they get sick, right? I'm going there when I'm sick. There's no culture of preventative testing. And unfortunately, chronic disease is seen as a inevitable aging, right? You get old, you get sick. Not something that you can catch and reverse early. So you can't really demand a test when you never heard it, right? Now, on the clinical side, longevity biomarkers are complex, even in the Western world. I mean, many European and American doctors don't know what an ApoB is, right? We know what LDL cholesterol and LDL, but if you go deeper, they don't know. And in Africa, the frontline isn't physicians, is actually nurses, as I mentioned, nurse practitioners, clinical officers in Kenya. They're trained on malaria. They're not trained on metabolic optimization. So there is no continuing education on longevity science, which is a massive problem. And also these tests that we're talking about, these fancy tests, they don't exist locally. So you cannot prescribe an ApoB testing when you're not when you're trained to manage malaria and TB, right? I mean, that's the harsh reality. So this is what actually gets, tested today. It's malaria, it's complete blood count, it's basic lipids, is glucose, is maybe have HbA1c, it's star rate, but very, very rare. ApoB, forget about it. I haven't seen one single ApoB test in Kenya. And this creates a vicious circle where, patients don't know what to ask. Clinicians aren't trained to test. And the labs which exist, they don't stock on reagents to do these tests. The governments on one side, they fund treatment, no prevention. And what the result is longevity remains a privilege for the riches. So our job is actually to break the cycle at every single link. And this is very, very complex. So, what does a longevity, I mean, we talk about longevity so much in our days, right? What does a scalable longevity system look like, right? Yeah. And how can we implement that? So first of all, biomarker infrastructure, and this is super important. You cannot optimize. I mean, who was saying, right? You can't change what you can measure, right? You cannot optimize what you don't measure. But we need to start affordable and to build up from there. We can't drop people at the top of the ladder. The second is the data architecture, right? Patient-owned healthcare records. We need to own our own records. We talk so much about this. We talk about interoperability. We talk about within decades, and this doesn't happen in a system which is basically built for sick care. And third is literally clinical intelligence. So if we can't train so many doctors, right? We can't train 1 million longevity physicians overnight. It's not in Kenya, not in Nigeria, not in the US, right? So how do we support the basic healthcare professionals to learn about this? And fourth is how do we deliver it, right? Hybrid physical and digital, super important. Urban hubs on one side, advanced diagnostics, mobile reach, super important. And in a world where like Kenya and Nigeria, in general Africa, where mobile penetration is so high, it's possible. So how, at Expand Health, we build our mission on a very simple thing, which is make longevity science accessible and actionable across the world, and because I live in Africa, across Africa. So we're currently operating in multiple countries. We have a clinic in South Africa. We do online in Nigeria and Kenya. And by 2027, we plan to be in 12 countries across the continent. And our approach is literally evidence-based biomarker panels. It's starting at the most affordable and impactful level. And using artificial intelligence powered assessments with this distributed network. And that's the only way I think this can work. So as I said, the layer number one is the biomarkers. This is a foundation. We can't build the way the Western world has built, using very expensive tests. So we've designed this progressive ladder where most of the patients can get CBC, blood glucose, malaria. That's the basics. And then we add diagnostics. We add A1C, which is super important, basic lipids, high sensitive CRP, and this already makes a massive difference. And then we can go next, and we can add fasting insulin, thyroid, vitamin D, homocysteine. And that's where the early adapters start to come in. And then we move to the next step. The full longevity panel, ApoB, Lp(a), sex hormones, aging biomarkers, everything that Aubrey de Grey talks about, right? But this can come later. And the key insight is even adding the basic biomarkers. We're already able to measure a lot of stuff, to get a good understanding of what's happening with these patients. So now why these specific biomarkers? How do we choose a test, right? I'll say the four criteria. One is clinical actionability. The second one is predictive power, because you can predict with anything, even in basic biomarkers. Accessibility is super important, and cost effectiveness. Why do we do one test versus another test? And the truth is, most patients barely get a CBC, and that's all right. Who can get a glycan age, a true age? Who can get a LP little a? Very few people, right? So already an A1C and a high sensitivity CRP is better than a fasting glucose, right? It gives you more understanding. And what can you do with $15? Actually, you can catch actually 70% of metabolic risk with $15 just by doing, basic biomarkers. So at Expand Health, we have all these panels which start with the basics and continue with more complex biomarkers if people can pay. Now, the second layer, super important, is actually data. And I think this is another super important thing because, data, there are a number of principles, and I'm very, very data focused myself. You need patient sovereignty. So you need to own the data, super important. It's not the data of the clinic, it's not of the insurance, it's not the doctor, it's yours. Then you need to have interoperability, right? The data needs to be able to move across systems. Privacy and security, we're not even talking about this anymore, super important. GDPR, HIPAA compliance. And then you need this, what we call the longitudinal designs, where the health is not a snapshot, right? It's a movie, right? It happens over time. So I think let me walk you through a patient journey. What happens in an Expand Health clinic, right? You book a blood draw first. You may have mobile phlebotomy, which comes to your home. The sample goes to the lab partner. Then the results are ingested into our system via an API. And we have an AI model which analyzes these results, performs a risk scoring, and then there is a doctor behind which reviews the results. And then there is a feedback loop, right? Once we know everything, we can actually come up with the interventions, help the patients implement them. We can track compliance, which is really, really important, how we make sure that people follow the treatment. And then, but this can happen really, really fast, 24 to 48 hours after the labs come in. And then layer number 3 is actually where the magic happens, is actually this AI driven clinical intelligence. And without this, it's very, very difficult because we have 2.5 billion people in 25 years from now. And there's no way to get clinicians to serve even like 1% or longevity clinicians to save 1% of these numbers, right? So what AI does and changes is, you take a basic nurse or a clinical officer, you put an app in the hand of the person, and these people can now become, as smart as the AI, right? So a clinical officer in rural Nigeria, armed with an AI tool, can flag pre-diabetes that risk that many, Western GPs cannot. And it's not about replacing clinicians. I think this is very, very important. It's about giving clinicians the tools for them to act better and to know better than anyone else. And then, the fourth layer is actually the stratification. Is when you have these multi-biomarker risk scores, you can measure diabetes, cardiovascular disease, cancer, cognitive decline, and this is super, super important. So we can compare the individual to the population averages and predict the trajectory, right? That's what AI can do. So at the current trends, you cross the pre-diabetes threshold in X months, which is super important. So you can tell people exactly what's going to happen. Prediction is extremely important. Then intervention optimization, personalized nutrition, so important. Exercise plans, how much the basics can do, right? Nutrition, movement can actually completely solve metabolic problems. Then we can do anomaly detection, right? The AI can flag unusual patterns before they are symptomatic, right? A lot of things we don't feel them. We see them in the data. And then is the adherence to the engagement. That's super important. So AI can actually help people to follow the plan, through messages, through SMSs, WhatsApps, reminders, etc. So our the AI that we build that expand, and the other people doing that is a hybrid system. It's a classical machine learning system, but combined with AI models, which come, like the likes of OpenAI and Claude now, and Gemini. And these large language models are actually amazing for critical reasoning. It's really, really good. They can convert biomarkers data from a laboratory test into natural language insights, and they can actually build personalized health reports, and they can build the decision support with and transmit this to the patients. So combining machine learning with big models is a solution to actually make this super affordable and then super deliverable to the patient. So I think that's a really, a case, 42-year-old male in Lagos, sedentary job, high stress, how many of us know that, right? Type 2 diabetes, A1C 5.6, in the pre-diabetic range, fasting insulin 18, high sensitive CRP 3.2, that's chronic inflammation, ApoB 105, so elevated cardiovascular risk. So the AI calculated his 10-year type 2 diabetes at risk at 34%. And the AI drafted an intervention plan, low glycemic diet, intermittent fasting, resistant training, 3 times a week, magnesium, omega-3, berberine, and then you retest in 3 months. The physician reviewed and approved it, no problem, and the patient implemented. 6 months later, A1C down to 5.2, amazing, check. Insulin down to 9, CRP down to 1.1. The person lost 8 kilograms. So this is really amazing. Without AI, this would have been impossible. So I think that's alongside above this specific case. Let's talk about the layer 4, which is how do we deliver to the people? And it's super important, right? The best biomarkers and the AI don't matter if the patient, cannot access them. So this hybrid model that we use, which is urban hubs, like we have in Cape Town, a clinic, we have DEXA scans, we have VO2 max, we have CGMs, we have physician consultations. With mobile reach, we partner with existing clinics, or we don't have our clinics, and with pharmacies, with mobile phlebotomy, telemedicine, community health workers in lower income places. And we have this digital layer, which is, apps, clinician dashboard, and wearable integrations. We have Oura Ring, Apple, Garmin, and very important to be culturally adaptive, right? So we adapt to the places where we are in terms of nutrition, in terms of what people do. So how do we scale this now, which is super important, right? Because again, longevity we know is currently for the 0.1 or the 1%. So urban proof of concept with, that's the plan actually, with patients across Lagos, Nairobi, Johannesburg, and Accra. That's the plan. Expansion into 12 countries, hopefully 50 cities that will touch about 100,000 people. And phase 3, where we look at the continental infrastructure, really a Pan-African platform. And phase 4 is how do we get this outside Africa? So we are already in Eastern Europe and the US, but we want to get to Latin America, South Asia, Southeastern Asia. And we're now somewhere between phase 1 and phase 2, with our Cape Town clinic and some online in other countries. The very important question is, how do we make money, right? Because we need to be sustainable. So the multiple revenue streams, direct to consumer, we have subscription in the clinics, we have paper panel options, so people come to the clinics and do diagnostics. We have premium services. We start to do a lot of B2B partnerships, super important. We go to corporates and we do corporate wellness. We engage, we enroll people from companies into our programs. Great for the attendance to work, great for they become more efficient, so their bosses like it. We do late data licensing, obviously anonymized. And very, very important, finally, it's about social impact here. So we have also grants and subsidized programs. So we look at obviously generate money, but also be able to provide impact, which for me personally is extremely, extremely important. But it's also very challenging. I need to be transparent, right? So as I said, number one is the cost. When the entire health budget is $50 to $70 a year per patient, per person, and no insurance is tough, right? And the system of a Western longevity clinic, it's difficult to apply for someone who pays $15. Number two, as we said earlier, is knowledge. How do we get clinicians how do we train clinicians? We can't really afford to train, nurses, but we can build technology and decision support that will turn any clinician into a longevity capable clinician, which is super, super important. And I strongly, strongly believe in upgrading humans with technology. And beyond this is actually the infrastructure gaps, right? We live in places like Lagos, like Nairobi, like Accra. They're not designed for longevity, right? I mean, Nairobi, hopefully at least there's some trees and some forests around. Lagos is more difficult, right? So we don't live in very, very healthy environment. With the level of pollution, I'm not even going to talk about it. But super important, I think this is something that people don't really talk about, is Africa is critical for the global longevity research. I think it's super important. So many different, nations, and it's a cradle of humanity. I mean, I come from, my 40,000 years ago, I guess my ancestors came from Kenya or somewhere, even if I was born in Romania. But we all come from Africa, right? So Africa has an incredible lifestyle and environmental diversity, urban, rural, traditional versus Western diets, it's super, super, it's an amazing place actually to experiment. And it's sad how little longitudinal biomarkers data come from the continent. I mean, this is almost nothing, right? I mean, we've tried, there are companies in Nigeria who tried to do kind of the 23andMe model and didn't really succeed, unfortunately. But there is hope, right? And besides that, we also need to talk about, ethics. How can we extract biological data for the benefit of the Western world without paying the local, the Africans, which needs to happen. So I think here the really, really important, the longevity medicine cannot be for elite only. I think it's super important to know. And we shouldn't impose the kind of Western type longevity medicine in Africa. And either we do it right or we don't do it at all. And I really like, what also you guys do at Afrolongevity, which is, rooted in the philosophy that resonates deeply with what I do at Expand and what I was doing at Ilara Health. So, you've articulated a vision of longevity rooted in the African knowledge ecosystem. And I'm trying to contribute as much as I can by providing this, biomarker validation for this traditional intervention. So yeah, I think that's that's what kind of I try to cover here. Again, I'm going to go to this AI augmented longevity physician. How do you have on one side a traditional physician with 20, 30 patients a day, seeing a patient every 5 minutes, and on the other side, the AI augmented physician, which where the AI pre-analyzes all the data, you get proactive risk alerts, the evidence is synthesized in real time, you build personalized plan, which is super, super important. And the result is actually what the clinician can have more time with the patient, right? Because that's what we always complain. The doctor doesn't talk to us. The doctor writes on an EMR. So more time for human connection, more time for counseling, more time for coaching, because that's, I think, what doctors are meant to be. Doctors will not be forced replaced by AI, but the doctors who don't use AI will be replaced by the doctors who use AI. So I think that's why AI makes a massive difference. So yeah, I mean, that's a quick overview of the tech stack that we build at Expand. It's React Native for mobile, Next.js for web, Node.js and Python for the backend. We use PostgreSQL for the database. And it's hybrid cloud, AWS, and it's HIPAA compliant. So wearable integration, as I mentioned, we integrate with Apple, Garmin, Aura, etc. So I think that's where where we can. I mean, I'm gonna pass quickly through this because I already talked about this. Yeah, I guess the challenge that we have is actually our aim is too big for a single startup, right? A single organization. So I'm trying to build an ecosystem here, where clinicians to join the network, researchers, because there's so much to we know what we know, but there's so much we don't know. We don't have researchers in our team. I think policymakers is super important, and it's going to be very, very tough. How do we get policymakers to buy in countries which, again, are more about survival? We need entrepreneurs in this ecosystem to build all these complementary services. And those are the entrepreneurs can be, doctors, can be clinicians, can be technology people. Again, my motto is own your health data. I think it's super, super important, and for us to be able to shape the health span. So, and I'll kind of end through how I envision, and I'm here for good. I'm not going anywhere. I've been in Africa for 15, 20 years, but how do I envisage Africa in 2035? So every adult has access to comprehensive tracking, chronic disease caught and reversed, before symptoms, AI augmented physicians. I really believe in health span, not just life. Longevity is important, and obviously we may contradict each other here, but health span, living healthy to the end, in my opinion, is more important than living 450 years or whatever, right? You need to be healthy. And I don't think this is science fiction. And these tools exist. And really the opportunity is now. We just need to get people together and believe and act. So let's build scalable longevity systems that work in Africa. So thank you. I'm going to stop here. I'd love to, any questions, anything I can answer. I try to go very fast to be able to do this in just about half an hour to leave time for questions for the next 15 to 20 minutes.
Powerful presentation, Emilia, as usual. So, whenever I have Emilia, always use him. Permit me to use that word because the last time, and because it's very difficult to get hold of him, the last time I saw him, he moderated a section. He did MC for the second day. He also presented a paper. So that's it for me. He's a fantastic speaker, and he is very good with moderating. And I think he started this project before me. He understood the ecosystem, and the first time we had a conversation, he tried to tell me what support's going on because I've been um, theorizing this the idea, and we tried to have difficult conversation. He told me, "Look, guy, I understand your country. I understand what you want to do, but it's going to be difficult." He presented everything, and when I tested the water, I realized that he even tried to be kind to me with his choice of words. So there are a whole lot of things that we have to do. And that's why we started the movement to have people on ground. Now we talked about trying to have system in place where in Nigeria, data governance is a problem, a huge problem. Most persons don't have access to their health history. Most parents cannot talk about their parents' health history. So you need to do recycling of medical tests is just to know what is evident in the present and then the past. We have nothing to present, and which is why we are building a data set which okay, Kifai also is doing so much. And so we have a whole lot of things that we work in Afrolongevity. And Emilia, I can thank you a lot. And I think there are some questions, couple of questions. I will take the questions before I ask my own question. So please let me.
Yeah, I'm looking from some, if there's any question. Yeah, I think one question here, please, in what ways can a biomed engineer fit into longevity research? Sure, biomed engineer is, finally, again, I go back to, I think basics are measurements, right? Diagnostics. Diagnostics are done by machines, right? By laboratory machines. A biomedical engineer can definitely help because, we can anywhere from, finding ways to bring cheaper diagnostic devices in the country and set them up for the local, setting infrastructure, right? Lab infrastructure is super important. Getting another thing that we're doing at Ilara Health is bringing online diagnostic devices which are offline. I mean, think of your cheap full blood count analyzer from China, right? $2,000. It's digital. I mean, it's not fully analog, but it's not online, right? You can't see how many tests you've done. Being able actually to place, a device on that machine, to bring that machine online. Let's think of a Raspberry Pi, for example. Being able to measure and have all the numbers coming from that full blood count machine in an EMR automatically uploaded. It's amazing, right? And that's the role of a biomedical engineer, right? And there's an example. So definitely, I mean, on the diagnostic side, I'm not sure if that answers your question.
Sorry, Mila, if I may, sorry, you can't. One thing that people need to understand that is that at the top, at the end of your presentation, you did present the people that we need in the industry,
Yeah.
and
Yeah.
it posits that the longevity ecosystem is a multidisciplinary thing in pursuit of life, because life is at the center of what we want to achieve. And every walk of life and field of study impact and affect life, even in relationship, basis relationship. If you're in a toxic relationship, your age accelerates. So we need industry leaders and experts in their areas of functioning. That is why gerontology is studied as a multidisciplinary or transdisciplinary course. So that is just my 2 cents. And Aubrey even studied biomedical gerontology. So that's the next question. Someone said you must talk more on the ethical implication.
I mean, my thoughts on ethics would be like, look, I think as I said, there's a massive data opportunity in Africa, right? The question is, what do we do with this data? I mean, ideally, you want to monetize it, right? If there is a way to pay, let's think of clinical studies, for example. It would be amazing to be able to do clinical studies here. Would be amazing to be able to do DNA sequencing, but then pay these people, not just use the data, bring the data to the Western world, and then make pharmaceuticals and selling them selling them for a fortune back to Africa. I think that's kind of my thinking. Like, how do we make sure that we measure? I mean, we extract data because data is important, but we monetize. I mean, not we, I mean, we as a continent, like the monetization happens, and there is a revenue back into the country, back to the people whom the data is captured. And look, I don't have the perfect solution, right? I mean, there are companies who they tried to do that, and then they didn't really succeed. There's not a lot of clinical studies in Africa, unfortunately, and that's a pity. And on the other side, the pharmaceuticals are super expensive.
Yeah. For Spiegel will expand on that tomorrow, and of course, it's a very interesting. It's going to be an interesting conversation tomorrow, looking at those longevity law and ethics in Africa. When you look at the history of Africa, Africa is at the threshold where they are conscientious about what people come to do in Africa. We've seen the effects of colonization, and the also the recent effect of systemic colonization, because we can't say that colonization is over. there is also systemic colonization ongoing, directly or indirectly, and it impacts everything that is going on geopolitically. So you cannot take away geopolitics from healthcare or whatever advancement in science and technology. It's always there. So these are the things that we are going to also look at tomorrow. What are you coming to do with African data sets? How are you going to utilize the data sets? Where bank are you going to plant them? We've been talking about property rights in the age of digital inheritance, but no one is talking about property rights in the age of biological inheritance. Talk about how we store our biological data sets and all that. These are also strong conversations that I expect African leaders to be having. And I remember in the field, there are institutions that are building certain things, um, trying to understand the usage of African biodata and the complexity that comes into play is that Africa is biologically more diverse than other continents. So it is very difficult. I know you have played this card, you understand how difficult it is to organize African data set and to use it to interpret situation that has to do with health. It's not going to be easy like that. It's going to be something that requires a lot of funding. And how many African entrepreneurs and leaders are ready to provide that kind of funding? It becomes problematic also because whoever funds you determines how you're going to operate and how you're going to do whatever that you're going to do. So most of the funding comes from Europe and America, and that is why we are always living at the mercy of the West. So thank you so much, Emilia, for expanding that point. I don't know if we still have questions in the room. I don't want to keep you so long. Any question in the chat?
But then can you elaborate briefly on your experience with health expanding postpartum health issues? Um, Interesting enough, we just had a baby, our second baby, 2 weeks ago. So been dealing with, postpartum health issues to a certain extent, mostly physical than mental. But I've seen obviously, postpartum issues in our clients. So interesting now because my wife and I have been, we talk every day about, different. I mean, she went through a emergency C-section, unfortunately. We wanted to have a home birth, and because we both believe in nature. But unfortunately, last minute there was a complication, so I had to go to a hospital. And luckily, and then here I appreciate the modern medicine. Sometimes modern medicine is amazing. I mean, modern medicine is amazing for acute care, and we accept it. So everything went well, but obviously there are post C-section issues, I'm been using our platform and everything covered the longevity, like the longevity doctor brain knows, to deal with what my wife is been going through, right? And can we do that? Can we take some supplements? Questions around recovery. And that's where AI knows, and we don't need to call a doctor to do that. We just do it from the comfort of our house, just using I have a Claude Code kind of brain, and we get all the answers possible, which I think is amazing. So yes, to this extent, I think postpartum health issues, as any other issues, can be solved, well, not solved, but you can get answers through AI. I haven't experienced personally, well, in our family life, mental health issues as a result. I mean, postpartum, which I don't know I can't answer to this, but I'm sure there are solutions.
Okay, someone is asking, how can we sensitize healthcare workers in rural areas on metabolic health? Because most of them don't even understand what it is.
Yeah, yeah. Yeah, and look, it's a fab, and that's another story. I was so you know that I was doing a lot of work in rural Kenya with the Ilara Health, and or some even with my team members. I was in a village and we had lunch, and one of my team members were just eating like fries, and I don't know what. And it's like, why? You can have some veggies, right? They don't cost anything. Just get an avo and get a red pepper. It's like, no, 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 because you need to understand culturally in Kenya, if you eat fried food, is actually the proof of wealth. It's like, okay, cool. So I think just to say there's there's an affordability issue and there's a culture issue. Affordability is, can you eat healthy foods for the same price as you'd go to I don't know, to like a really, really cheap supermarket and buy processed food? And it's debatable. I think not everyone, can. I think fruits and veggies are super cheap here, and I think in East Africa, to a certain extent, is more affordable on fresh. And I think everyone can buy, fresh food, fresh veggies. Um, but the challenge is actually you get to like, organic, and that's obviously becomes expensive. But on the other side is, when you have a population which eats more than 100 grams of sugar per day, and this is cultural. I was in another small clinic a couple of years ago here in Nairobi, and the wife of the clinician was really nice, inviting me for like a high tea, right? And the high tea was actually some tea with milk, with like really dead milk, supermarket milk, and with a lot of sugar. And there is some, I don't know, some bread and pretty much it. And and she was also a clinician. I mean, she was a nurse. And this was like late morning. I was like, if I eat this now, I'm gonna like fall asleep in the next 2 hours because I'm gonna go for high sugar and low. So how do you educate people? I think this is difficult. So we have the affordability issue on one side, and you have the education on the other side. How do you get someone? And it's not just rural; it's urban as well. Actually, it's funny enough. Urban is more problematic than rural because people living in the villages, they have their fruit, the veggies in the garden. People living in the city, what are they gonna do? Well, they're gonna order at, like the burger and cheap, fried chicken, and they're gonna have a lot of sugar. They're not moving, and we see this in the data actually. Much more problematic the urban care health than metabolic health than the rural. At least in the village, people just run around, right? They don't have cars, they don't have motorcycles. Um, so it's really tough. I think education is the biggest issue, even over and above the financial side. Uh,
Education, sorry, education is not just the key. I think the strongest problem that we have in Africa is transfer of knowledge. And
is what
sometimes
what is
trans transfer of knowledge, transfer
yeah,
of knowledge,
sure.
transfer of knowledge. Because you can explain everything if it is not translatable in local terms. Can I teach longevity in Igbo language without bringing in English? That is the basic
Yeah,
question. So the
yeah,
idea of what we are doing here is train the trainer, give them the foundational knowledge so that they can go to their various community, their chapters. Once they pass through this cohort, once they graduate, they are being given issued certificates. They joined a particular group, and then they are now directed down to their chapters. They
yeah.
go there, organize programs, grassroots sensitization, decide how they want to translate their playbook, right? So transfer of knowledge, the key thing that we are doing here is to train people, and this is not going to end with
Mm,
this program. We'll be having series of programs to see that people are armed properly to do this. So we want to
yeah.
grow something that is formidable in this great continent. And someone asked another follow-up question. Sorry, Emilia, I'm taking your time today. They say
Ah,
you you mentioned that there are entrepreneurs
yeah,
in your ecosystem. In your opinion, what role can entrepreneurs
yeah,
play in promoting longevity in Africa?
yeah. And maybe I'm gonna mix this question with another question before, which is, for a clinician in a city like Calabar, Olegos, what's the minimum viable infrastructure needed to transition from a practice or a traditional practice? So finally, clinician entrepreneurs, I think is the answer. Is how do you I think everything starts with the doctors, everything starts with a clinician because you can always build spas and fancy Pilates and whatever. Um, but I don't think there's a solution. I think the solution is actually being an entrepreneur, clinician or clinician, and build infrastructure because people still need to go to a physical infrastructure. Online longevity, I don't really believe into it. It's definitely like very, very difficult in Africa. You still need a brick and mortar place somewhere, and you can actually treat people afterwards. But indeed, you can get finally what does longevity? What does I wouldn't let's not even call it longevity. What does functional medicine means, right? A functional medicine provider, it's a doctor, it's a GP or whatever, who now says, okay, instead of spending 15 minutes with a patient and giving you an amoxicillin at the end or whatever, give you a paracetamol, I'm gonna ask you, how do you feel? What did you eat yesterday? Are you stressed? What's happening at home? How's your work? How do are you happy? Etc., right? And based on this, and based on how these people feel, you come up with a plan which will start with the basics, right? Before the pill, start with like what do you eat? Do you eat properly? Do you eat like 5 times a day, or you eat, you fast a bit? Do you move enough? Do you walk? Do you run? Do you pray or meditate? How do you sleep? Do you watch TV at midnight and soap operas, or do you go to bed at 10 and then meditate maybe a bit before? So that's how you can transform a practice into a call it a longevity or a functional medical practice. And then afterwards, you can add treatments on top of it. You can add, your hyperbarics and your red lights, and you can do IVs. But even before that, the basics need to be in place. And this is also for any entrepreneur. I think infrastructure is super important. There's so many sick people. You need to get them somewhere. You need to do something with these people, right? You need to get them to a place and help them, treat them, show them data, very, very important. Show them that they improve. Because if people don't see any measurable outcomes, it's going to be very difficult, right? Losing weight, very difficult to lose weight. And 90% of people on a weight loss diet, they stop after a couple of months because they don't see an improvement. But they don't see an outside improvement. There may be an inside improvement. Maybe their hemoglobin A1C went down. Maybe their LDL went down. Maybe their ApoB went down. Maybe their insulin went down, right? But they don't see it if they don't measure. So that's an answer to how an entrepreneur can make a difference by thinking, infrastructure, solutions, AI, monetizing. Obviously, you need to monetize these, but also providing impact and not doing that just for the richest of the richest who want, peptides and stem cells and right because that's not a solution. Um, Yeah, I think that's. Is there anything? Oh, how can you sensitize healthcare? Oh, no, Meto. Yeah, I think I've answered to all the questions here. Is there anything else? Just bring them up.
Yeah. Thank you so much, Media. I really appreciate, and I think I've dealt with all the questions and most of the questions that have been answered in previous classes, and I think I'm super excited having you again, and I don't
Thank
know
you.
if we're going to see you in Addis. Um, Addis, I don't know how your trip and your
Yeah,
wife
maybe.
just
Well, like, let's talk when I'm not sure the dates, but yeah, maybe it's not that far.
okay. So August.
All
So
right.
congratulations again. Thank you so much for the time, and hope to see you anytime soon.
Thanks, Asi, and thanks, guys, for listening. Bye
Take care.
bye.
Bye.